So today we're going to talk about full arch flexibility. Through the last 2 to 3 years, 3 years ago, I probably started doing 1 or 2 cases a year, and now we're up to probably over 100 for the office now between myself and all my partners. And we've been talking about full arch, taking teeth out, putting implants in, immediate load. But what I've been seeing, especially the last several months, is patients coming in with existing implants and failing dentition. And the question is, can we use those implants? Are they useful? Are they in a good position? And most importantly, do we know what implant it is? A lot of times these implants were placed over 10, 15, 20 years ago, and it's hard to get the information on what type of implant the patient has in its mouth. We're going to talk about some guided surgery techniques and the use of scanning technology. A lot of the cases I've done is that we use scanning techniques in the pre-op workup and also in the final design. So whenever a patient comes into the office and they come in for a consult or they're even ready to proceed, after we discuss that they are a candidate for immediate load, I always break it down to 2 things. How are we going to temporize them? And I really have a full discussion with them, usually at the consult visit, but even when they're ready to go, to express what are they looking for? Are they okay taking their teeth out, implants in right away, and are they all right wearing a denture, or they want something fixed? So we try to really pinpoint on where this patient's heading. Most patients today want something fixed in their mouth. So especially with all, they hear the advertisement, they see the commercials, they want teeth in a day. So most patients today do want screwed in teeth when they leave the office. Every so often you have a patient, especially with COVID, wearing the mask saying, you know what, doc, I could wear a denture, I could wear nothing at this point. But since COVID is, the mask restrictions have gone down, everyone wants immediate load with fixed as they leave the office. And then my other thought process, and I discussed this with the restorative doc, is where we're heading this. Where's the final restoration going to be? But that's for a later discussion at this point. Temporization. 3 ways how I think about this. Are we going to do a chair side conversion? Is the restorative doc going to come in and we can convert a denture? Number 2, are we going to take an impression after the implant's in and delay load it? I usually do this a lot with Town and Country. A day or 2 later, the patient will go back to the restorative and they will get a screwed in temporary. And number 3, they would get a pretty much a mill or printed temporary that was already digitally designed heading into the case, and they will get that after the implants are in the day of surgery. So these are the 3 different scenarios I think about when we start to design and think about where we're heading with the immediate load case. And I've started with, I first was a delayed load because I did a lot of early cases with Town and Country. And then I moved more back to a denture conversion. We would have a denture at the day of surgery. And then I went all the way to digital and have everything done or ready to go that day. And now in the last few months, I pretty much have gone back and forth between all 3. It's really the case selection, the dentist we work with, the lab, the patient. So we usually all sit down and discuss where we're heading with the temporization. I always, when a patient comes in for a consult, I usually have these little script pads that I give out to referring docs. And I always think about, the patient comes in for a consult, we always get a CBT scan. Intraoral scan is already, it takes a few minutes in the office to do it. Even if we're not doing digital at this point, the staff knows just to scan the patient as part of the workup. We take some photographs and, decide, depending on where we're heading, are we going to have a lab technician help us the day of surgery? Is he going to be involved? The next few cases we're going to talk about are some of the guided cases that we've done. And the 3 main systems we work with now, and they're probably well known to everyone in the audience, is Smile in a Box, which is a Straumann product, which I use mostly now. Nsequence is I used earlier on when I first started doing digital workflow. And Chrome is another major digital workflow that I use as well. And these are the three major digital workflows I use on my immediate load cases. It's fantastic when these cases go well. Everything is pre-designed. You get it all in a pretty much a box. You get these beautiful models where the implants will go. You get all the implants here. Sorry, not the implants, the abutments, temporary cylinders are all pre-cut, pre-picked out for you. In these other little containers is the PMMA that will go in. And all three systems, depends how they organize it, all presented and designed beforehand. So everything is, I always tell my staff and the patient, we design everything for the patient. Everything is custom made for them. So we just have to execute the day of surgery. So these are the three major digital workflow systems that we use today. And this is Smile in the Box. I just wanted to show this is actually the PMMA that the patient will get in after the implants are in the temporization. To the right here is actually the implant guide. And then this one is actually how we fit, we put this in initially over the patient's existing dentition. And these are a fixation guide that helps us align the pins later on for the case. And this is our first patient we're going to talk about today. It's a well-known patient to my practice. I've worked on her several years. Her name is Barbara, a fantastic patient. And she's a patient that started with just a few implants, and then slowly the rest of her dentition started to deteriorate. She still works. She works Monday through Friday. She didn't want any downtime. She wanted limited visits in the dental chair. So as soon as she came in, again, I did a CBCT scan, intraoral scan, some pictures, and the reason I wrote smile on this diagram is I really wanted to see how much soft tissue or gingiva she showed on smile. Is she a candidate for immediate load case? How much bone reduction we're going to need? And also, can I use her existing implants in planning? And this is her existing bridge here. She has decay under this bridge. So after talking to the restorative doctor, after doing an initial workup, I realized the two existing implants that she has up here on the top left here are Straumann BLTs. And when we did our workup, I realized that these implants can be utilized. They show no bone loss. The abutments and the abutment height and the positioning will be served very well if I just added 4 additional implants. It's really comforting to know that you could use 2 integrated implants when you're doing an immediate load case. So we designed this case up with Nsequance Workflow at the time. And it's a great workflow in terms of they actually help us pick out the multi-units. So we know the cuff heights of the multi-units. We know the angulation. So it really makes us really predictable in terms of where the implants will go and can we use these existing implants. And with NC Workflow, with all these immediate load cases, it's all about the treatment planning. And then after we treatment planning and know where we're heading, it always flows the same workflow. We do extraction, we reduce bone, we put the implants in, multi-units, we place the temporary, we do the pickup, and then we screw it in. And that's pretty much the recipe in all these workflows. And the day of surgery, again, we have our implants, we do our CT scanning, we do our guides, we have the multi-units, we have the bone reduction, we have the temporary cylinders, screws, protective caps, conversion materials, Voco or chair side, and we always have everything ready to go the day of surgery and already picked out beforehand. And I call this organized chaos. When you walk into the room, We have everything that you're ever going to need. Even if there's something that goes not as planned, we have backup multi-units of different sizes and different angulations, and we have different series of implants as well in case we need to change out or put a different size implant in. So this is the day of surgery with Barbara. Again, refresh. We're going to use these 2 existing implants. Make sure the staff reminds me several times that we're not taking out these implants. Day of surgery, we're removing the bridge. You can see the existing teeth. You can see the implant crowns that are cemented in. We took off the crowns. These are stocked abutments we have. We'll screw them out as well. In the top left picture, I always have to reduce a little soft tissue for closure, so I remove some at the time of the extraction. This is the bone supported guide that we put in, and you can see I circled the stock abutments just to see how everything lines up, and you can see how they're in a good orientation with the surgical guide as well. And this slide I like to point out, after we put our implants in, you can see the bone height is pretty nice. So we're going to know that everything is pretty leveled, and we'll level it out with the multi-units as we go forward. And in her case, we also decided from the design that she didn't need more than 1 millimeter or 2 of bone reduction in the front as well. So that's another reason why we're able to incorporate the back implants. This is a closure, and you can see the multi-units are here. And you can see I just showed this picture of the original implants, 1 and 2 in this position. And the multi-units come in a variation of sizes that we talked about before. They come in straight, 17, 30, different cuff heights, 1.5, 2.5, 3.5, and they're all pre-planned beforehand. But there has been times that after we do the case, we decide to take out a 17 and we need a 30 or a different height of the implant. Different height of the abutment we need. And I'm going to show you this next slide, which is great. This next slide is 4 months after extraction, media placement, and media temporization. And this is what you really want to see. You want to see really nice keratinized tissue around these abutments. You want to see the cuff of the abutments above the soft tissue. And the reason why I circled this, this is actually a Nobel 5.0 trilobe. At the time of design, we did not incorporate that implant, but in the final, the patient will have that implant incorporated. So I went to uncover it. And this is one of the themes of the lecture, is how we're going to incorporate that trilobe in with the Straumann components. But like I said, this is what you want to see when you remove the temporaries. You want to see nice soft tissue. You want to be able to access those abutments with impression copings or scanner bodies without impingement of the soft tissue. In this case, I won't have to give the patient, well, the restorative doctor won't have to give the patient any local when he goes in to do impressions or put scan bodies, because there's no soft tissue around these abutments. So I'm going to have Keith Williams take over and talk about how Straumann integrates other implant systems in the workup.
Just sliding right in here. Sorry about the background. So a couple things that I think are unique, and hopefully this slide is a bit educational on this meeting. But Straumann, has all different brands. Some of these are technology brands, our printers, whether it's 3Shape, Medit, our own printer, Virtuo Vivo. Also our ability to work across multiple platforms. So part of the reason we work with Medentika is what we're talking about here, is this multi-platform prosthetic as a German company that we started working with in 2013 and eventually acquired. They've been on the market for almost 20 years now, and they're really known for precise manufacturing. Just go back to this slide for one sec. So precise manufacturing. They're manufactured in Germany. They're all over the world, 45 different countries, and they do 13% of the overdenture market. So they full arch dentistry, removable, fixed is kind of what they specialize in. And you can see these are all the different brands that fall under the Straumann Group umbrella. Now we're focusing mostly on Straumann today, but Medentika is an important part because it gives us the flexibility to mill a final restoration, a prosthetic restoration across multiple platforms. So they really try to optimize the connection. So if you're working with a trilobe connection or others, they try to improve upon it. You know, how you've probably heard my talk track around, you know, knock off abutments. Usually they take away from the connection. Medentika tries to over-engineer and improve upon it, and that's kind of how they work around some of the limitations through FDA. So what's nice about this is if you have an existing Nobel implant and you put a Straumann full arch case in, you're going to want a warranty on the product, and this will give you a warranty across the whole product versus having some Nobel parts mixed in with some Straumann parts or some Astra parts mixed in with some Straumann parts. So it's a nice system that allows, you know, what we're talking about tonight, full arch flexibility. And you have local support, local warehousing, manufacturing, all that stuff. So what is it that we actually can achieve with this is you have really a universal multi-unit abutment. So it's a standard connection. It will work with Nobel, Nobel Active, Biomet, Astra, Zimmer, and you know Zimmer and BioHorizons are you know really the same connection as well. So it will be flexible there, and it also works on our tissue level. So we have a couple different tie-based copings, short and tall. So you can see the small coping that would embed into your zirconia restoration. We have the temp cylinders that you can put on your SRA. And what's nice is once you put this SRA in, let's say this case with the Nobel implant, it's the same workflow, same process across the board. So same 0, 17 degree and 30, same digital options. So they have a nice metal scan body and CAD/CAM analogs. So you really have no limitations with this, with existing implants in a patient. So if you see a case that has 2 implants failing dentition, what are you going to do? You know, we moved away from whatever system you're using. This allows a solution for that. And if you have more questions on this, obviously reach out to me as well. So I'm going to let Dr. Jurman take back over, and thank you.
Again, thanks, Keith. That's Keith Williams from Straumann. So that's, having this flexibility of having Straumann have the access of giving different abutments and parts for other makes of implants really ties in to the theme of, can we use existing implants, and do we have the parts to incorporate that into our final plan and design? So I left this picture up here. Again, I know I keep harping on it, but with the digital planning, we know the type of implant, we know the multi-unit, we know the positioning of implants, and again, we're able to know beforehand we could use the existing implants, and we have the multi-units for it. So this is a patient with the temporary in. She had a PMMA. Again, we used the Nsequance Workflow, and once we put this in, it leaves me with a warm feeling inside, knowing that she had 2 integrated implants holding this restoration, this temporary restoration, and especially that these implants are in the posterior region, because I find that is usually the most crucial implant in design of these cases. Is the most posterior implants I feel take a majority of the forces during the healing phase, and then during the healing, I always find those implants actually to be the ones that, if we do have a problem, are the ones that fail. So if I was able to keep 2 posterior implants in the planning and they're well integrated and in good position, I love to keep them. And then again, this is her inclusion. And this is the final, and you can see we used BLX implants and we use BLTs. And this is, again, this is the temporary PMMA. And again, I always love to match our digital plan, a virtual planning, with the post-op X-ray. and I love when it matches up very closely. So after the patient, after 4 months of healing, and I knew all the implants were integrated, she went back to the restorative doctor, and he was going to restore her using scanning technology. So the first thing, she comes to see him, and she was happy with her temporary after doing some adjustments with the occlusion and maybe reshaping or recontouring a tooth or two. She was happy with the temporary. He scanned her with the temporary, scanned the bite, screwed off the temporary, and then put in the scan bodies. Now, scan bodies come in, I like to call it two types or two flavors. One, scan bodies could go into the multi-units, or they could go directly into fixture. So obviously, in this case, we used the ones that go into the multi-units. So now she's being scanned with the multi-units, but it has to be done in a way that you capture as much soft tissue as possible and as much as the hard palate as possible as well. The scan in the lab needs to have enough landmarks to stitch these images together. And this is what it looks like on the 3 shape. And then, so that's visit 1. Visit 2 is that the restorative doctor will get back a digital try-in or a jig. He will put this in, and again, this is pretty much the try-in. He would make sure that it fits passive. He would make any corrections or suggestions. He'll check the bite out, and after he does this try-in, he sends it back to the lab, and then the lab will. These are some more images from the scanning, and the lab will come back and show some designs of the final. And in the final, I just took some of these images off. These images that were given to me by Andy Kim from iDesign, and you can see how in the top screen how these will go into the multi-units and how the contouring of the prosthesis will look in the final. And you can see the screw access holes as well here. And then the top left obviously is the design, and the bottom right will be what the final will look like in the patient. And this is Barbara with the final in. And again, very happy. I think the restorative doctor told me it was almost 3 visits for this. I did see her on a 4th time, just another, occlusal check. But this took 4 visits. He didn't give any lidocaine, no local. Most visits were under an hour, the most. And again, for a patient that didn't want to spend much time in the dental chair, this was a great case with a great result. Again, just as she is 5 months later. And this is the final, again, BLX, BLT, and we could use any implant systems, like Keith was saying, if this was Nobel, if this was Zimmer, 3i, so we can incorporate in mixing implants. This is another patient or a final case I'm going to talk about. This is we're looking at the lower dentition, and it was interestingly because when I first met her, she didn't have she was missing teeth on the bottom right, and what I did was using digital planning is that I placed these 2 BLT 3.3s just buckle to the inferior alveolar nerve. You can see that the nerve is actually looks like it's going through the apex of the implants, but actually through 3D planning and digital planning guided surgery, I was able to place those implants to the buckle. But now her anterior dentition is failing, and she wants some teeth on the back left. So again, I with CBCT scan and workup, she definitely had enough bone in the anterior region to put some fixtures, and she wanted she didn't want to wear a partial. She didn't want to wear a lower denture. She wanted something fixed the day of surgery. So we did our workup. We used, in this case, again, Nsequance Workflow. we extracted all her lower teeth, and you could see the back left, she has these BLT implants in, and after adequate bone removal, which we have to do at least 4 to 5 millimeters of bone removal, it will be at the same level of those posterior implants. So the first thing that we do after extraction, we get our bone foundation guide in. We put our monostrut in, which helps guide the occlusion of the bone foundation guide. We have the patient bite down. We put our fixation screws in, and now we know we're in the proper orientation. We level the bone. And again, you could see in the back left here, you can see the BLT implant is pretty much at the same level as our bone reduction. And then we put our implant guide in, and that's what shows in the right slide here. The left slide shows the bone reduction. And again, you always need at least 15 millimeters for these prostheses that we make. After we put our implants in, we put the multi-units on, which were pre-planned. We put these temporary cylinders on. These temporary cylinders were pre-cut. Straumann now makes a slender temporary cylinder, which serves as an advantage for these cases. Just to go back one slide, this is the gasket that helps prevent any material getting under these temporary cylinders. And you can see in the back left here, we actually put a rubber dam on top of the cylinder because the gasket wasn't fitting well around the multi-unit we placed. So to extra security, we put this rubber dam there to prevent overflow and make sure there's no that material getting under an undercut. And then we put our, she has a PMMA that was pre-planned. And you can see these screw access holes are coming out in the right orientation. These are fixation pins that bring the multi-units in, and we know we're right in the correct orientation because they lock right in. And then we do our conversion and pickup. And these are the two materials that we use today, depending on the lab technician and depending on the restorative doctor. We use either Voco or chairside. It's really preference on the both bisacryl materials, dual cure, and it's really just on the restorative doctor what he likes to use. Again, multi-units are in and sutured, and you can see the back left here. This is a yellow. The rest are all BLXs, and this one's a BLT. That's why it's colored yellow in this picture. And again, I love showing this image. This is the plan of the 4 implants that match the pan on the top. This is the digital workflow on the bottom left. You can see the BLT, which is the correct orientation. We didn't feel it was necessary to go this far back with the prosthesis. We had good torque in all the implants. Again, she had very good bone. And then with the integrated implant, we felt we had some nice security with this immediate load case. And this is her final. She just came back a few weeks ago, very happy. She has posterior teeth, especially in the back left. She likes how she looks, she's eating well, and she's very happy. And this is the pre-op and post-op. We didn't wind up not using this back last implant. What I got from the restorative doctor was she kept feeling that she was biting her cheek. So he decided not to use that implant. All the implants you could see didn't show any bone loss. They're well integrated and had really high torque when we placed them. So this was a great case. So this is the last case I'm going to show very briefly. This gentleman, I actually did his upper last year, and he wore a partial snapped into these implants on the bottom. He had these core vent implants placed about 25 years ago. He didn't let his lower anteriors are failing, and he wanted the same thing done on top, done on the bottom. So the question is, can I use these implants that he has? The core vent implants, they've been in there for a long time. They do look like they're in good position. But after we do a digital workup, I realized that he needs a lot of bone reduction. and these implants cannot be used. And this is why I put these yellow lines here. This is where the bone is now, but this is where I have to be with these new implants that are placed. I have to extract these teeth, take out these implants, and level the bone to this level to get the enough restorative space for the prosthesis. And you could see with digital workflow, I could see where his nerve comes out, and I could see also how I'm going to angle those most posterior implants. So this was actually a chrome case that we're actually doing in a few weeks. We use chrome in this case because I haven't used them in a while. I just wanted to use a different system. So this is a last case I'm going to show of when we do not use implants. Obviously, we don't use implants if there's any bone loss, if we don't know what implant it is, or the platform is in a wrong orientation or wrong depth. Sometimes we don't use existing implant systems if they don't make parts for it. A few months ago, I was told they don't use a multi-unit for a tri-lobe implant, but so in that case, we didn't use it in the final restoration. And again, positioning. And the reason I showed this slide is that this woman has 2 posterior implants here, and if we use these implants, you could see the platform of the implants are at this level. But when she smiles, we can't put the implants here. We have to put them above her lip line. So there definitely would be there'll be a step in her original implants and the new implants. So we told her that we have to take out our old implants and put in new ones in. So you have to know from planning, can you use those implants? The platform is going to be the same. Where's the level of the implants going to be, especially when patients smile? And with bone reduction, will the old implants be in a correct orientation? And this is where I was talking about. This is where the implants will have to be after bone reduction, and this is where our existing implant platform is, so that we cannot use those implants. So this is some useful tools that we recommend everyone should have, or if you're doing a lot of these cases. This is actually a Salvin right angle torque wrench. Very useful to use. You could set on the bottom here. I lost the mouse here. You can set the torque value, and it's just very useful to use, especially when you do multi-units of 1730 degrees and the posterior, you can't get in there. I definitely recommend everyone should have one of these right angle torque wrenches. And then Salvin also makes this universal implant kit. It comes in all different variations of different screw heads, for Straumann, Nobel, Astra, Zimmer, BioHorizon. So if you don't know what implant it is, it's nice to have one of these kits in your office. So I definitely recommend everyone to have one, or at least know someone that has one so you can borrow one. So this is our team that we work with. It's actually, if everyone, you just saw Keith Williams before. This is Nex Martinez. This is our lab technician that does many of these cases with us. He comes sometimes for the workups with the patients. He comes during the case. He comes for the post-ops. He's very integrated in our team, and I definitely recommend him if anyone has any questions about the lab aspect of these cases. There's Krista White in the middle here. She's an implant coordinator, a go-to person. So I definitely recommend everyone to have one of these in your office who knows the patients, knows all the ins and outs of these cases. If anyone has any questions about these cases, she's the person to talk to. This is actually one of our patients. When we finished the case, he was very happy. He wanted to join in the picture. So we just did an upper on him the same day. And this is myself here, Dave Jurman. So again, I want to thank everyone for being here and joining in. I want to thank all my partners who help me with these cases and sometimes see the post-ops. Danny Fleischman, Jason Nella, Tracy Rosenberg, Brendan O'Rourke, Rob Bachkalupa, Barry Bass, Peter Schaffenberger. We all work together. We all help each other out. So if you have any, and my partners do a lot of these cases as well, and sometimes we do them together. So again, I want to thank Keith Williams Angelina can handle any questions when it comes to the CE stuff. And we do have future lectures coming up, so please join us. And if you have any questions, please reach out to me and Angelina, Keith, Krista. Also, as a side, I do have a few of these cases lined up over the next several Thursdays. So if anyone wants to come by, check how we do them, stop by the office, please reach out to Angelina. And again, just want to thank everyone for joining us today. Angelina, any questions? I forgot to ask. Do we have any questions out there? I know we went through a lot of material.
Yes.
I have one question for Keith as he's sitting next to me. I know Straumann uses a scan. What scanner do you find that most people use today, or what do you recommend out there?
I'm going to slide in here like this. So yeah, I mean, really, it's just about capturing data up front. So a lot of times we get asked with these full arch cases, and I have this conversation all the time, whether it's a full arch immediate temporization or it's just a single unit BLX with a temp, right, at time of surgery, which we like to do. So you just really need to capture the data with an iOS scanner. And then we can marry that with the cone beam and our CARES software, and we can deliver a guide with a single unit temp or a full arch temp. We support the Medit scanner. We have our own Virtuo Vivo and the 3Shape. So it's more about digital data capture than anything. And at that point, then with the software innovations and the connection to our milling facility, we can really manufacture anything. And we do partner with local labs on that as well. So it's a nice feature to have. And I think the initial part of that data capture is an iOS scan. They have them at their practices here. So, if you have a patient, mutual patient, I'm sure you guys could do a scan on that patient for them. Or if you're interested in hearing more about that for your own practice, we can talk about that too. Question was, any issues on waiting the approximate 48 hours for delayed load?
Yeah, so originally all my first cases were done delayed load. We take the teeth out, implants, put the temp, not put the temp, but do impression, and then 1 or 2 days later, the patient would get the prosthesis. I would say half the time it went smooth, but the other half, the patient was swollen, uncomfortable. The restorative doctor had to give local. So it just makes I think today's day and age, most patients want everything done the same day if we could. To have the patient come back a day or two later, especially leave the office with a denture or nothing the day of surgery. I don't know. I feel like patients today want the teeth screwed in, and they want to leave looking like they have teeth and then don't come out. So, but to tell you, the question is, any issue waiting 48 hours? No, you could if you want.
And Dr. Jurman, one more question here do you only do these cases on Thursdays?
No, we don't. The reason why we do Thursday is that we try to have one location because we find that we keep everything that we need a lot of parts and materials and adequate room for these cases. So we typically try to do in Levittown because it's centralized. We have a big room, and we usually try to do it on a Thursday because most patients want to piggyback the weekend. But we do sometimes do it on a Wednesday. But let me know or contact, like I said, Angelina, and anyone want. I don't mind if there's or I actually like a lot of people in the room. I like a lot of noise, so the more the merrier. So if you want to come and watch and pick my brain or pick Nex's brain or Krista's brain, please come by. We'd love to have you.